Welcome to today's webinar, HIV and the Aging Brain. I would like to introduce Victor G. Valcour, MD, PhD, Professor of Geriatric Medicine at University of California, San Francisco, in San Francisco, California. Welcome, Dr. Valcour.
Hi, good morning. I will go through a couple slides and then get into the talk. I'm excited to see so many people joining, and I see some familiar names. So hopefully I'll be sharing some information that's new to many of you. I have just a couple slides to share with you before we go on. First of all, if you've not previously logged in on the new website, you will need to use your email address and reset your password. In terms of CME information, you can get 1.25 CME credits for this designated activity from IAS-USA. For those of you looking for nursing or pharmacy credits, we also have been approved for 1.25 hours of credit. Important for you to know that evaluations will be available on the IAS-USA My Activities page at 5 p.m. Pacific Standard Time today. Some of you may not know that 30 years ago I was a high school teacher, and I always wanted people to master the information. It wasn't so important to me that the grades had a bell-shaped curve. So in that spirit, I'm going to repeat again one more time that the evaluations will be on your IAS-USA My Activities page at 5 p.m. today. Generous support for today's activity has been received from these sponsors. You will be polled through this session several times. When that happens, a separate window will show up with the poll question. Choose your response from the poll, not from the chat box, from the poll. Responses will be displayed after the poll closes. Please type your questions, any questions you may have, in the chat box, and they'll be sent to me later in the meeting. So we'll start with this poll question. Please answer the poll. And another poll question. Let's see how well people are listening. Oh, very close. Very good listeners. And one more poll question. Okay, let's see where we go from here. So I am going to move into some of the presentation, I believe. This slide just lets you know a little bit about any disclosures that I have. I've consulted for Merck and Viv Healthcare, and my slides were reviewed by Dr. Spudich. So I had thought that there were a couple important learning objectives for today's seminar, and I've listed them here. So I hope that by the time this talk is done, you will be able to define HIV-related and other factors, particularly cerebrovascular disease, that contributes to cognitive impairment in older people living with HIV. I'd also hoped you could describe why Alzheimer's disease is of increasing concern for older people living with HIV, and describe the challenges in distinguishing HIV-related impairment from that, particularly of Alzheimer's disease, in people as they're living into old age with HIV. I have a couple pretest questions that you can answer. The first one is, when an older patient living with HIV presents with new cognitive problems, which will be the most helpful in distinguishing HIV-related impairment from Alzheimer's disease? One is brain imaging with distinct patterns of atrophy that differentiate the two. Number two is CSF analysis of HIV RNA levels. 3, a pattern of neuropsychological testing that is with clear deficits in a subcortical pattern in HIV. Or 4, CSF Alzheimer's disease biomarkers of amyloid and tau. So please take your best shot at this question. Good. These are quite difficult questions, I think, and even my own narrative around this has changed over the years, so I hope to give you the most up-to-date information that I know and what I do in my clinical care. Here's another pretest question that you could answer for me. Which statement is supported by the current literature? 1, the frequency of Alzheimer's disease peaks at 80 years of age. 2, CSF levels of HIV RNA predict cognitive impairment in most people living with HIV. C, the frequency of hand is similar now to what it was before the introduction of antiretroviral treatments, although the severity is less. Or 4, progression of disease is the most common course for people living with HIV-associated neurocognitive disorder, or HAND. This one, I think, is a little bit more important to have a sense of and not as controversial. So I am happy to say we'll have some learnings in today's discussion. So I'm going to move now on to some of my slides. And again, if you have any questions, you can place them in the chat box, and the facilitators will be collating them. At the end of the presentation, I'll take a look at them and see if I can answer some of them. So a couple key points that I wanted people to understand in today's seminar. Impaired cognition remains an important challenge despite the antiretroviral therapies. It affects probably about a third, is my best guess, but maybe up to 1/2 of people being treated with antiretrovirals despite the fact that we can suppress plasma viremia in these individuals. And from my experience, chronic inflammation is one of the more common reasons why this is continuing to occur, or at least I should say it's most closely associated in the literature to biomarkers of inflammation, making me think that there's a cause and effect, but being able to determine cause and effect is quite challenging. But as a consequence of this chronic inflammation, what I tend to describe cognitive impairment in the setting of HIV is as a mild to moderate fluctuating encephalopathy. So some changes in cognition that can be better from time to time, and I think a lot of attentional deficits is what I've gotten used to seeing. I also wanted people to understand that among factors that may be contributing, non-HIV factors that may be contributing, cerebrovascular disease for older people is a common comorbidity. And I'll share with you how frequent in some slides. The co-occurrence of Alzheimer's disease or other age-associated dementias, so Lewy body dementia, frontal temporal dementia, progressive supranuclear palsy, all of these types of neurodegenerative processes, is now a reality because all of these diseases are age-associated. And as people are living into older age, we now have to grapple with the possibility that one or two different diseases could be occurring, HIV and another neurodegenerative disorder. So far, my experience is that distinguishing Alzheimer's disease from HIV-related cognitive impairment is just a very large challenge. I've been surprised many times in my own clinical work both ways, in people I thought had Alzheimer's or people I did not think had Alzheimer's disease. And I'll share with you some of those narratives today. If you look at the frequency of cognitive impairment, I would argue that it's a little bit difficult to know for certain. The most commonly quoted number is 50%, and this came out of the Charter cohort, which is a study done in the United States. But one important caveat to that is that many people were incompletely treated in that cohort. It was an epidemiologic study that represented a cross-section of what the environment looked like at that time that the data were captured, but it didn't try to particularly answer what the rate of impairment would be for people who are successfully suppressed with antiretroviral therapy. And as you look through the literature, it's a bit difficult to find great studies that would suggest that. Some of them, some of the international studies I've listed here, but even in these, some of the metrics are hard to know how certain they are. But my estimate is probably about a third of people living with HIV with suppressed viremia have some level of cognitive impairment. When I talk about cognitive impairment in the setting of HIV, I do mean all parts of what our brain does, not just the piece that is around memory, concentration, motor slowing, but also I think it has a direct impact on some of the behavioral, apathy, depression, and even in earlier days we've had some case reports of mania and agitation related to HIV. And I think there still remain some motor aspects to this. Some of it is conflated by neuropathy in terms of gait, but some of it is not. Procedural memory may be impacting our ability to do things quickly, and one of the more common things that I see when I'm testing patients is difficulty with some rapid task where there's a lot of mirroring to the opposite side of the body, or probably use of more parts of the brain than would typically be needed to accomplish more simple tasks. So the motor component, I believe, remains common. And so I would argue a couple important points from this slide. One is that in terms of cognition, multiple cognitive domains can be involved, and that does include memory. Often I'll hear people say that the phenotype of cognition in HIV has changed with more memory, but if you look at some of the very early papers published in the HIV epidemic, memory was impaired in those studies. So I'm not sure that it's necessarily emerging as a new domain. One thing I would point out is often what is considered to be a memory it can be explained by poor attention. So it's not possible for somebody to really make memories when they're not paying attention very well. And so what patients often feel is that their memory is poor, but what we can demonstrate sometimes with detailed cognitive testing is that it's the attention that is really a problem, and without attention it's hard to make memories. This is an important distinction because it may help us understand how we distinguish this from Alzheimer's disease, which is often a memory problem, but also it opens up a door for compensatory strategies for people living with HIV, that if they improve attention, sometimes through writing things down, keeping notes, they can often improve. I would also point out from this slide that the course of HIV-related impairment does not tend to be progressive. If that were true, we would have an epidemic of HIV-associated dementia right now. But what we have instead is a very large number of people with what seems to be a fluctuating cognitive impairment with inefficiency without necessarily progression on to a dementia status. And that's a key distinguishing feature from neurodegenerative processes. This information can be very powerful for people to understand as they're grappling with this very irritating inefficiency in cognitive ability, that in fact, in my experience, and doing this for 2 decades now, most of the people that I care for do not progress on to dementia due to HIV alone. So I wanted to switch gears a little bit to describe to you the evidence that makes me feel inflammation may well be underlying much of what's happening in the cognitive inefficiency that we see in the setting of HIV. You can find data that support plasma and autopsy markers linked to cognitive performance. For example, the soluble CD163, which is cleaved off from monocytes when they're activated in blood, correlates to cognitive performance in the Women's Interagency HIV study. Other markers of CD163 on cell surfaces, or CD38, both inflammatory markers, again are associated with progressive worsening of memory performance. Chronic inflammation persists even when antiretrovirals are started in acute HIV. So there's a paper in 2017 that said even when we start the therapy as early as possible, we're still seeing some indication of inflammation in plasma. And there are several autopsy studies of interest. This one that I've noted here, and I've tried to provide references wherever I can, links soluble CD163 to brain pathology at autopsy. So there's quite a bit of evidence there. One of my favorite studies was one that I've noted here, which it was done in the UK, and only 12 asymptomatic HIV-positive patients, all with undetectable viral load on good treatment with a high CD4 cell count. So these are people doing fine in the community and not having any symptoms. What this researcher did was use an inflammatory marker, TPSO, which binds microglia in the brain, and then did a PET scan using that marker, comparing it to 10 controls. And what they found is that this microglial activation marker was increased as a group in people living with HIV who were asymptomatic compared to the 10 controls. What was most interesting is although all of these participants were normal on cognitive measures, if you regress the amount of binding on performance of executive functioning, there was a link. So the more binding there was, the worse their performance was on executive functioning tasks, even though these were all within the normal range. So I think this was really eye-opening for me in this realm. More data would connect some inflammatory markers, again linked to monocytes, MCP1 and neopterin, to the integrity of the brain. And that's what you're seeing in the slide to the right. These are damaged integrity of the white matter tracts in people living with HIV, or I should say abnormalities, presumably damaged. And it links to the amount of inflammation that is measured in the plasma. So what's more is the amount of these abnormalities by diffusion tensor imaging correlates to worse performance on cognitive measures. So again, all associative, but concerning that there's a connection between the amount of inflammation that one can measure, even in the setting of viral suppression, and abnormalities that we see in both cognitive performance and the integrity of the brain. This is another study looking at rates of atrophy, and this is a study that I published, and it is a bit controversial in that it's an outlier compared to two other contrasting studies, but it's congruent with two other studies that did find the same thing. So when I see these types of findings in the literature, I think they're great scientific opportunities to try to untangle why there are differences. So I'll tell you a little detail on this. In the study that we published, 62 mostly male older people over 60 with an average age of 63 living with HIV for 2 to 3 decades, some as many as 4 decades, and had documented viral suppression for 3.5 years. When they were compared to healthy aging adults, we found accelerated brain atrophy in multiple regions across the brain. Now the contrasting studies, the two important caveats. One is that the comparative group were not necessarily healthy aging people. In one study, they were also enrolled, but HIV negative, but enrolled from clinics that tested for sexually transmitted diseases. So the attempt was to be more demographically matched. Another study excluded people with substantial cerebrovascular disease and did not find this. So I think this may be clues to why it's seen in our study, but not in those. Is it possible that this is an effect of cerebrovascular disease causing shrinkage in areas of the brain? Or could it be that there are other factors that are associated with our participants who are over 60 years of age living with HIV that could be causing some of this? It's unclear. But these are important findings, and certainly for people living with HIV over 60, notable differences in atrophy rate compared to healthy controls is something that is concerning. I did mention before cerebrovascular disease, and at some point I'll have to stop using this slide, but it is only 5 years old at this point. The important thing is that these data were captured from autopsies that were done between 1999 to 2011. So those of you who treat HIV know that there were differences in the antiretrovirals that were used prior to 1999 and of course in the early 2000s, and whether any of that could be contributing to some of the factors we see is of note. I would add to that, for many of the people living with HIV over 60, they lived through this era, so this could be quite applicable to them in terms of the amount of cerebrovascular disease. But what this slide is essentially showing, and I don't have it highlighted particularly, but the B and C, you can see the thickening of the vessels. That's moderate, and in C, severe cerebrovascular disease. And what this study found is that half of the people who succumbed to autopsy during that time had either moderate or severe cerebrovascular disease on autopsy, which is a substantial amount. What does that look like in my clinic? Well, these are two study participants of mine. The top is one participant, the bottom is another. And what I end up seeing is a lot of white matter abnormality on flare sequence. And I would say the top pattern is something we have grown to think is more typical of standard cerebrovascular disease, and the literature would support that. With this kind of capping around the periventricular regions, this is probably at least a moderate amount. I've certainly seen worse than this in some people living with HIV. The pattern on the bottom, you can imagine, looks distinctly different with more discrete lesions. And yet, as we went through our normal healthy controls here in San Francisco, we did find people with this pattern. We see both patterns in the setting of HIV, and often we see a combination of the two. And mostly, I would say, in people over 60, some in people over 50, and not so much under that. So it makes me wonder if there is some level of a legacy effect here, as I noted on the prior slide. What's important about these white matter lesions is that they do link to abnormalities in integrity of the brain by diffusion tensor imaging, but also to cognitive performance. And there are several slides that show that the burden to which you have that cerebrovascular disease is linked to how you perform on cognitive measures. There is one study that demonstrated that the amount is no different than in people living without HIV into old age. And even our data would suggest that if you look at the means, the differences are not so profound. What we end up seeing in HIV is a number of people with a very high level of white matter lesion burden. But in this one paper, there was also a suggestion that being over 60 was perhaps a marker of having a higher burden. And that's what my clinical experience would be as well. I tend to see that level of white matter burden mostly in our more aged population, and particularly over 60. So this slide is an answer to one of the questions that I asked before. The red line is really the population risk for Alzheimer's disease. And what ends up happening in Alzheimer's disease is that your risk doubles every 5 years. So at the age of 60, perhaps 1%, by 65, 2%, and by 74%, by 75, 8%, by 80, 16%, and it continues to double every 5 years for as long as we've been following people. So your Alzheimer's disease risk does not plateau at 80, but continues to double, and by the time you're in your mid-90s, your risk is about 50%. What the blue line represents is what people hypothesize is the added burden when you have one comorbidity, particularly cerebrovascular disease, and there's a theoretical increased amount that has been, some people have tried to quantify. What ends up being more important is that you could be asymptomatic with the pathology of Alzheimer's disease, but if you also have cerebrovascular disease, you become symptomatic more readily. And so it's probably just an unmasking as much as anything else of the symptoms. But why this slide is really important is that we do see cerebrovascular disease in people living with HIV. And so it makes me wonder whether there will be a higher risk for symptomatic Alzheimer's disease. What's more is that living with an inflammatory profile is also worrisome, that you could have an increased risk for Alzheimer's disease. And these are questions that I just throw out as hypotheses because we don't have data to answer these questions. It's also important, this dialogue around cerebrovascular disease, in terms of what we might be able to do to prevent cognitive problems. This slide is, I think, a very critical paper published out of the Lancet 2 years ago, not addressing HIV, but simply addressing dementia in older age and the prevention of dementia. And what this working group hypothesized is that we may be able to prevent as much as 35% of dementias worldwide if we begin to address some of the factors throughout the life course that are linked to dementia. And this is particularly important in countries that are low and middle income, where aging is rapidly occurring and also change in lifestyles is rapidly occurring to an extent that we might be able to have an impact in these regions. And I've highlighted in bold the factors that have been linked to cerebrovascular disease as a potential target for some of the things we can be telling our patients now, we can be doing with our patients now, is really to be careful about hypertension management, trying to encourage physical activity, stopping smoking, preventing obesity, and wherever we can, aggressively treating diabetes. So this really concludes a lot of what I wanted to share with you around where we are right now with HIV-related cognitive impairment. So I'll pause with these summary points. So the first one is that impaired cognition remains an important and frequent challenge in the era of combination antiretroviral therapy. Cognitive impairment affects 1/3 to 1/2 of patients despite suppression of plasma viremia, which is, in my experience, increasingly possible with the armamentarium of medications that we now have. I think I've shared with you a fair amount of evidence that chronic inflammation underpins or is associated with this mild to moderate, what I call fluctuating encephalopathy. I've also pointed out that cerebrovascular disease is a common comorbidity, particularly among older people living with HIV, and that it contributes to the amount of cognitive impairment we see on cognitive testing. Finally, for all types of dementia, whether people are HIV infected or not, there's a growing momentum to really identify and treat modifiable targets. And many of them are linked to the cardiovascular burden, and I would add many of them are linked to the social determinants of health. So these are opportunities for us. A similar approach may be useful for older people living with HIV who may have both HIV-related and non-HIV-related concerns. So for the second half of today's presentation, I wanted to share with you what I think is one of the most interesting and challenging areas of science right now, and that is really trying to understand distinguishing Alzheimer's disease from HIV-related cognitive impairment. And I call this one of the most important issues in geriatric neuro-HIV right now, and certainly a challenge that we see in clinics with frequency here in San Francisco. So the reason why this has become apparent is, of course, the aging phenomenon. In that slide before, looking at the rate of neurodegenerative diseases, you may remember that under 60 years of age, the rate is less than 1%, and I would argue less than 0.5% for people less than 50. And that's largely where the HIV epidemic has been since, over the 4 decades that we've been caring for people living with HIV. But this has changed in the past 10 or 15 years, and I think the tipping point really begins to be important around 60 years of age, although in our research studies and in the clinic, I'm increasingly seeing people in their 70s and 80s. One person now approaching 90 years of age that we care for who's living with HIV and has a cognitive syndrome. So we really haven't had to address this. One could ask a number of important questions around this topic. One is, are people living with HIV into old age at higher risk for neurodegenerative syndromes, and particularly Alzheimer's disease? So the easy answer now is we don't know. This has just not been understood well enough. The second question might be, will the phenotype look different? That is, will they present in a different pattern of cognitive impairment or a different pattern of motor findings or behavioral findings? Again, I would argue we don't know the answer to that. There's just not enough data from the clinical front for us to understand that well. And I think another quite important question is, will the course differ? Will people have a more rapid course, or one person has argued to me, a slower course? I don't know. Again, I can go on anecdotal data of people that I've cared for, but I don't have good solid data in this realm. I have been really worried about some people that I have cared for that have had both diseases, and so I think that this is something really worth digging into and understanding better. So when I talk about the subject, sometimes I get this question, who cares, right? Why bother? There's futility with both of these illnesses. People who have lived with or known, and nearly everyone I imagine on this call has known somebody with Alzheimer's disease, shares the sense of futility in a disease that is relentlessly progressive and for which we have not been able to identify a cure. And so people will often say to me, who cares? Why would you want to identify this? And I think there's a similar concern around HIV-related impairment. We have fairly good evidence that the rate of impairment is higher than one would expect for age. And I've shared with you a lot of mechanistic information around what may be underlying some of this. And yet, for doctors, there's a sense of futility in what can be done beyond things that you would commonly really work hard in the clinics to achieve. And so these are questions that I think are worth addressing. It's very easy to address because you can just think about your own situation or somebody that you care for very much and say, how would you appreciate going to see a doctor and the doctor saying, well, I can't tell you if you have Alzheimer's disease or if this is just HIV, but we couldn't do much with either of them anyway, so have a good day. I think that would be terrible, and we really don't want to do that. Others would say, well, the phenotypes will present over time, and I think that is true because they have markedly different trajectories. With HIV, we see a fluctuating cognitive impairment, so what I can see sometimes testing people year to year is that they do decline, but I have to wait until the third year to see, and often you see recovery. And so watching people 2, 3, and we have people in my studies I've followed for more than 10 years, we can document this fluctuation in cognitive performance, whereas my patients that I care for with Alzheimer's disease, this is not a pattern that I see. I see this progression. As I mentioned, there are a few pharmacological therapies, adjunctive therapies I would add in the setting of HIV because we have a very powerful therapy in antiretroviral therapy, but we don't have adjuvant treatments. But there are a lot of things that people would want to do, for example, planning for care, advanced directive, juror power attorney. I think there's these you would do with everybody anyways, but certainly with a diagnosis of Alzheimer's disease, the urgency changes some. And I think clarity of diagnosis is really core to our principles of good care. As I said before, I think people living with HIV are at a higher risk for a delayed diagnosis of Alzheimer's disease and other neurodegenerative disorders. I've mentioned to you before whether the course or features or timing difference is really not known, but I would share there are some worrisome pathological data that have been accumulated over the past several years, and mostly around people who have succumbed to autopsy, been kind enough to allow us to understand what's happening with their brains. And in these studies, we do identify many of the proteins that are seen in these neurodegenerative syndromes at a higher rate than would be expected for people living into older age. One of the more common ones is amyloid, and there are a number of papers, I've listed some of them here in a review paper, that's showing a higher rate of diffuse plaques. So this is the same amyloid that one would see in Alzheimer's disease, but in Alzheimer's disease they accumulate into neuritic plaques. There are not data that I've seen suggesting a higher rate of these Alzheimer's type neuritic plaques in people living with HIV, but a higher rate of the diffuse plaques. And the association between those is not that clear, but it is worrisome that there could be higher risk. But there are other proteins as well that have been described in people living with HIV, including this protein TDP43, which has been seen in frontal temporal dementia, and alpha-synuclein, a protein that is seen in Lewy body dementia. So not only something I would worry about with Alzheimer's disease, but at least theoretically, and again, I don't say these in a way to be alarming, but it is worrisome to me that we would find these in people living with HIV who do not necessarily have these neurodegenerative syndromes. I'll switch here to somebody I cared for, and I've taken out all identifiers here, so this is anonymous, and I've changed some of the factors so that it's clearly not identifiable. But a 75-year-old right-handed man, and I imagine those of you who are clinicians, this is not unfamiliar. 16 years of education, sought evaluation due to memory changes, and because his brother died of Alzheimer's disease at 79, and now at 75, he says, my symptoms look just like his. He's been living with HIV for quite some time, since the mid-1980s at least, when he was diagnosed. And he had a nadir CD4 cell count that was not terribly low, over 200 cells. He's never had opportunistic infections. Currently on an integrase inhibitor-based regimen, and a CD4 cell count of 850 with an undetectable plasma HIV RNA. In terms of symptoms, he describes subtle, insidious decline in memory and executive functioning. Executive functioning are kind of multitasking type things where you're trying to hold two things in your brain at the same time. I tell people sometimes it's like trying to put together a party, the things you have to do to organize these events. He says that they started 5 to 10 years ago, and he feels that they're progressing. He's functionally independent, has had some depression for a long time, but considers it mild now and treated, and has some comorbidities, including hyperlipidemia, hypertension, osteoarthritis, gout, and a myocardial infarction in the past. When he was examined, his neurologic exam was not very remarkable. There was some slowing in serial sequential tasks we call the Luria sequence, which I see with great commonality in HIV. And he had some long-standing neuropathy. And when we did some cognitive testing, he had some impairment, and I'll show you some of these in the next slide. This is a test we call the Montreal Cognitive Assessment. Some of you may be familiar with it and have used it in your studies. And you can see right off the bat in the upper right-hand corner, this individual had difficulty drawing a clock accurately and putting the hands on the clock to designate the time 10 minutes after 11. There was a little bit of challenge in what we call confrontational naming, unable to name a rhinoceros. When we looked at the next line that's called memory here, but really is registration, one thing is notable. When reading 5 words to him, he recalled 3 of them the first time I read them, and 4 the second time. That is inefficient learning or attention problems. For many of us, reading 5 words and repeating them back is not a difficult task. So this may not necessarily be memory, but could be poor attention. And in fact, if you go down to the nearly the bottom in the area that's called delayed recall, you can see that in fact he spontaneously recalled all 5. So although he may be arguing that his memory is not good, at least on this screening test, it's better than one might have anticipated. But as we went into more in-depth cognitive testing, we identified that there was in fact some impairment in visual memory. And we also noted that there was some impairment in language. So the rhinoceros was the tip of the iceberg. He had difficulty naming 15 items and only named 12 of them. Those are both factors I would say I don't commonly see in the setting of HIV, and it made me worried for this individual in terms of having potentially another neurodegenerative syndrome. The motor findings on the group pegboard and the finger tapping are much more common and not something I was as worried about, typical of HIV. And when I looked at his brain imaging, it was essentially normal for age. So I was really puzzled with what to do with this individual. And one might think of these possible next steps. could you modify his antiretrovirals for greater CNS penetration? Now, this individual has 5 to 10 years of cognitive symptoms that he's now presenting with some cognitive impairment. I would argue that there's no evidence that an approach of changing antiretrovirals in this setting would be of any value. Now, of course, there are times when there's a CNS escape, typically a more subacute or acute process, where changing antiretrovirals is critical to do. Those are quite rare cases, and an individual with this type of a history, my suspicion would be quite low. That would not necessarily mean I wouldn't do an LP, because I might in this individual to make sure it's not escape, but I don't believe this history is consistent with escape, or typical anyways. Should we initiate cholinesterase inhibitors for him to treat Alzheimer's disease? Well, it would be an empiric choice. You would have to make an argument that you think this is Alzheimer's disease. It's possibly wrong because he may not have Alzheimer's disease, and there's no evidence that this medication would help in the setting of HIV. The management of Alzheimer's disease, we use cholinesterase inhibitors to manage symptoms. So that may not necessarily be a good choice as well. Can you watch and wait? Well, this is a reasonable thought, thinking carefully with the patient, the risk of delayed diagnosis and what that might mean. And finally, can you test CSF markers for Alzheimer's disease or refer to a specialist? And these, I think, are both possibilities. We accumulated evidence comparing Alzheimer's disease to HIV and published these in a paper in 2017. Let me walk you through just a few of these factors. First of all, when you look at neurocognitive testing, there are some factors that are at least hypothesized to differ between HIV and Alzheimer's disease. The punchline here, though, is that you can have variance on both sides. People who present with an HIV cognitive impairment that's largely memory, or people with Alzheimer's disease who present with executive dysfunction. So this is not a very specific way to approach diagnosis between Alzheimer's disease and HIV-related impairment. Imaging, one might think, could be helpful. Certainly, the classically defined ways of the brain's atrophy in the setting of HIV and Alzheimer's disease differ. However, in true context, when you're in the clinic, distinguishing these two is incredibly difficult to do. So I think that this is something I wouldn't necessarily argue with. In terms of A beta and tau, I think this shows some promise. We do see that biomarkers A beta and tau are affected by inflammation, but what I'm increasingly learning in my personal experience is that one can use these markers in CSF when they're consistent with Alzheimer's disease, yet we're finding many cases in the setting of HIV where one or the other is perturbed, not typically both of them at the same time, which makes me much more worried for Alzheimer's disease. And then finally, genetic testing has not been terribly useful either, with the most common Alzheimer's risk factor, APOE4, being elevated both in hand and Alzheimer's disease. So let me just walk through a couple more of these to make sure that I've made it clear. In terms of neuropsychological testing, I've already mentioned to you there's considerable overlap between the two diseases. So I think it's difficult to rely on classically defined descriptions, particularly what you will often hear as a subcortical versus a cortical pattern. This is sometimes true, but not always. And certainly from my personal experience, I've been burned on this one. I do think that language tends to be more preserved in HIV, but I don't think that's always true. And as I mentioned before, memory was one of the early domains identified in the setting of HIV. I would say currently I'd worry a little bit more that attention is underlining a piece of this as well. I mentioned to you about imaging, and what's really fascinating to me is that when we asked the computer to distinguish people with hand from people with a mild cognitive impairment due to Alzheimer's disease, the computer can do it with greater than 95% accuracy. I have 90 here from the paper, but we've now achieved 95% accuracy. So machine learning with a computer might be an interesting way to try to distinguish these two. Yet from the naked eye, I would argue it's very difficult to distinguish these two. I mentioned to you before that when you look at CSF biomarkers of A beta, total tau, phospho-tau, all these markers that we look at in the setting of Alzheimer's disease, numerous papers have described perturbations in these markers in the setting of HIV, even among younger people. There are several caveats, though. These papers would typically include people that have detectable virus. So these are people differing than the types of individuals you might do a lumbar puncture on. If you were to do a lumbar puncture, most of us wouldn't be looking at examining until we have plasma virus under control. Then we would look not only to exclude escape, but also for some of these Alzheimer's markers. So looking at people with studies where there's a mixed population of detectable and undetectable may not best inform clinical practice today. I would also argue that in many of the papers, the individuals enrolled in the studies were more advanced and had more of a dementia rather than a mild impairment. So what I'm arguing here is, in fact, we may have some benefit in using these CSF markers, and it's something that deserves more research. Some of you may be aware that we can image now for amyloid in the brain using a PET scan, and in research studies we can image for tau. So there are some informative papers here that are suggestive of potential benefit, but again, some important caveats. The first paper basically said that if you're young, asymptomatic, living with HIV, you don't, and no cognitive impairment, you don't have a positive amyloid scan. So that's an important negative finding, that the PET scan would not be positive in people living just because they're living with HIV. So that's quite important. There also was a case report of a 71-year-old who had both HIV and Alzheimer's disease, and in that case, the amyloid scan was positive. So that gives you a pertinent positive, that in fact it will be positive. I'll tell you that one of the challenges with the amyloid scan is that healthy people without Alzheimer's disease can sometimes have a positive scan, and the rate goes up with age. That means they have some amyloid identified in their brain, but do not have Alzheimer's disease, which also requires tau, among other things that could contribute to being clinically important in Alzheimer's disease. So already this scan has positives in the setting of not having Alzheimer's disease, making it probably not the best test for this setting. And then there's one paper on tau imaging as well that is basically assuring us that the tau imaging is not positive in people living with HIV. So the take home from this slide, expected readings for amyloid and tau in the setting of HIV occur. What we don't know is what it looks like when it's HIV and Alzheimer's disease. Amyloid imaging is largely not clinically available and highly expensive. And as I said, there's this rate of amyloid positivity that occurs in the absence of Alzheimer's disease in people without HIV, so the scan may not be the most important thing. So I would suggest in this individual the next thing to consider doing is the CSF assessment to see if neurodegenerative biomarkers are positive for Alzheimer's disease. That would be probably what I would do in my clinic. At the same time, you can assess plasma and CSF HIV RNA at the same time to assure yourself that you don't have escape, which I think is unlikely in this setting. So I'm going to wrap up this section of the talk just to say that due to advancing age of people living with HIV, the likelihood for Alzheimer's disease will increase. Like people without HIV, the rate of Alzheimer's disease is likely to increase exponentially with age. Whether the overall rate is higher in people living with HIV is simply not known. Distinguishing Alzheimer's disease from HAND is an urgent issue right now. It's an urgent clinical issue that I feel every day that I'm working. Somebody either in my research setting or my clinic, I'm somehow addressing this issue. Alzheimer's disease biomarkers, including PET imaging and brain imaging, are not likely to be enough. CSF may add some clarity. And the patterns of neuropsychological testing deficits overlap. So that's a little bit more challenging to use, although I think it's an important step to use, and I use it in every individual that I examine. So I want to end in kind of like, let's do something now way. What can we do now? And that's where I've decided to end the talk. What do I do in my clinic with people who have this? Well, first of all, I think adherence to antiretroviral medications and maintaining persistent plasma suppression is critically important. So many times patients ask me that they think the medications are causing it. I can't fully exclude that some of the clouding that our patients feel can be attributable to some of the medications. I simply can't with confidence tell them that I'm certain that's not true. But I can tell them certainly that without treatment, they're at high risk for things to get much worse, and that we try to choose the best medications we can to minimize side effects for long, healthy quality of life in people living into older age. I think referral to a specialist if Alzheimer's disease is present, or if you're comfortable considering an assessment of these neurodegenerative markers, particularly in people that are suppressed. It gives you an opportunity to also assess for CNS escape, but usually the clinical prodromes for these two disorders are different. You need to consider CSF escape, although very rare, I think, even in my personal experience, but also as you review the literature, you don't want to miss it. And so we end up doing more lumbar punctures than I would otherwise typically do, just to try to exclude that. All of you can think about polypharmacy and also poly supplement and poly-recreational use. These are all things that can be addressed in our populations as they get older. I'll refer you back to the slide from the Lancet Commission identifying modifiable risk factors, and this could be a nice teaching point with your patients to go through these and say, if this commission has any, is at all right, we may be able to decrease your risk. And these are the things they identified through the life course. What can we do about managing social isolation for you? What are the optimal ways that we can address depression? How can we improve your physical activity? Can we optimize your treatment of hypertension? What can we do around weight loss? I think these are all opportunities for conversations with your patients. In the setting of HIV particularly, I think there's room for compensatory measures. Given that there's a lot of attentional deficits and there's a speed component, sometimes patients will respond to just slowing things down or making lists, using alerts, using reminders. Because what I've learned in most people, and not all, they can make the memories if they are told 2 or 3 times. These are the people that come in and say, I have to reread my books. I read a paragraph and I don't realize I just read it. I have to go back and reread it. Those are the types of attentional deficits that we see in the setting of HIV that I think we can reassure our patients that, that we realize it's true and it's present and we endorse it. And you will have to reread and you have to work on processes to try to increase your attentional capacity. I think for some people this becomes a social isolation issue. I've had patients tell me that they're uncomfortable going out in public settings because they can't keep up with the banter and conversations. They're just not as fast in taking in information and giving and telling jokes or being quick-witted, which they pride themselves in. And for some people, and this is something you have to be quite cautious about, people are empowered with the information around that and do tell their friends, and their friends compensate for them and recognize it to try to avoid social isolation. From my experience, the trajectories are different, and even this alone sometimes is very reassuring to patients. I can't say it with certainty, but I can tell them that in my experience, this is what I tend to see, and sometimes that's very empowering for the patients that we care for. So let's go back and look at these questions one more time as we close out this talk. When older patients living with HIV present with new cognitive problems, which of these do you think is going to help you and distinguish the two diseases? Well, the good news here is that the CSF analysis of HIV RNA received the fewest scores, and I didn't, clearly say that in the talk, but most people living with HAND have undetectable CSF HIV RNA, And I would say hopefully 100%, if not close to that, of the people that I see in my studies and have undetectable CSF RNA. Because if they have detectable, we go ahead and we treat it. And what happens most often is that they don't get better because they don't have a classic CNS escape pattern. And so they have what people are beginning to call asymptomatic CNS escape. So I think the RNA levels are not helpful. The patterns of neuropsych testing, I agree, are not something I would exclude. I continue to use them. I think they are helpful. But more and more, I'm moving towards CSF Alzheimer's disease markers of amyloid tau. And expecting perturbations from one or the other, which I'm not fully certain how to interpret, happening in probably just less than half of the people I see. But I've only seen a handful of people where the pattern is absolutely consistent with Alzheimer's disease. And in those cases, I worry they have Alzheimer's disease. So that's where my clinical experience is moving, although the evidence for that in the published literature, I have to tell you, is lacking. So this is really how we're moving forward from a clinical perspective. The second question again, which statement is supported by the literature? So in this one, the frequency of cognitive impairment in the setting of HIV has not changed with the introduction of antiretroviral therapies is the correct response. And although I think the benchmarks on these are not very solid in terms of the estimates, I would argue that that's probably the most appropriate statement, and certainly many people have said it. The key point here is that cognitive impairment remains an important challenge despite suppression of HIV RNA. So I am now going to start looking at some of the questions that I see in the chat box. I think that's where I will go. And please, I feel like I'm a little bit on the spot here, and so hopefully I can answer the questions for you. One question that I see that I'm somewhat happy to see is that some people have been describing anecdotally that they don't see Alzheimer's disease in the setting of HIV. In fact, there was a publication that said because doctors haven't described Alzheimer's disease in the setting of HIV, maybe it doesn't happen as often. Well, I argue in this that let's stick to the science. What people are seeing anecdotally and or publishing is very different. When the first case report of Alzheimer's disease came out, it was publicized in the popular press as the first patient having Alzheimer's disease in the setting of HIV, and many of us who have been doing this for years shrugged our shoulders and said, well, I've seen a handful of people with Alzheimer's disease living with HIV. So I think we have to be very careful about anecdotal evidence. I think the truth is we simply don't know. And I've tried to make an argument in my slides that there are some indicators that could be worrisome, but I don't know. I'm just being honest that we don't know the frequency, we don't know the trajectory. These things are just, we're now at the beginning of that. There's a question about HIV-1 and HIV-2. Do they both have cognitive disorders? I don't know as much about HIV-2. I know that it has been associated with cognitive disorders, but whether it's been connected as tightly to HIV as HIV-1 is, I'm not certain. There are some questions about which antiretroviral class may be associated more often than others, and that's not a topic that I'm an expert on. What I end up doing when I start going into which medicine I would want somebody to be on, I can often get into trouble. I think the HIV providers do a much better job with that. The side effect profiles in general of antiretrovirals have to be thought out in the context of the individual. And I think that the cognitive piece of that is just one piece of it. So I think it's a broader question than just what's happening cognitively. I think of it as from a more holistic perspective of what's happening in the liver, what's happening in the heart. But I'm also uncomfortable answering that question because it's not an area that I spend a lot of time doing research on. So there's one question relating largely around environmental factors and stigma, and whether there's any causal associations. Where I would go with that is the work that we've done certainly around depression and the published literature around depression would connect very much with some of those factors, and depression itself is linked to HIV-related cognitive impairment. It's hard for me to imagine that there isn't a connection with some of these issues and how people perform or able to live their lives in a cognitive way. So I endorse that question. I can't immediately cite literature that may be supportive of it. There's one question around asymptomatic neurocognitive impairment and whether that progresses to symptomatic cognitive impairment. And of course, there has been one paper that suggested increased mortality in people living with asymptomatic neurocognitive impairment and some progression to symptomatic impairment. For those of you who don't know this literature very well, in the Charter cohort, 50% of the individuals that they tested in an impaired range, so when compared to control. So that's where the 50% come from. If you dig deeper into that question, of those 50%, 2/3 of them did not have any symptoms. That means only 1/3 of people who test poorly on cognitive testing have cognitive symptoms. And it suggests that the lion's share of what we call HIV-associated neurocognitive disorder is asymptomatic. So what the Charter cohort showed in their analyses is that these people that were asymptomatic were more likely to progress to symptomatic, and that they had some links to all-cause, I think mortality is what they found. I would add to that a very small paper that wasn't picked up very much around what does asymptomatic mean. In the setting of Alzheimer's disease, in early Alzheimer's disease, if you ask a patient whether they have problems, what you'll find in many cases is they don't identify that they're having problems. We describe that as an impairment in insight, and we completely accept that in the setting of Alzheimer's disease, and that's why we insist that there's a proxy informant. And the proxy informant tells us, usually from the back of a room, waving their head back and forth saying no, 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 that in fact there is a lot of challenges at home. What happens for me in the setting of HIV is often our study participants and patients will come in without an informant. So we're relying on them to have recollection. Also, for people that are older living with HIV, some of them have not been employed to the level that they had previously been employed, and as a consequence aren't being stressed as hard as they might have been in the past. Some of them are on retirement, and some of them have disability from other things. All of those factors, I think, make it quite difficult to understand clearly whether any deficit on a cognitive test is associated with a clinical finding. There are many things that make it murky. And so I begin to think that these people claim to be asymptomatic would probably be symptomatic if we had proxy informants and others who were telling us what was going on. So I think the asymptomatic informant, I appreciate somebody bringing that up, is an important one. And certainly from the clinical perspective, they don't come to see me in the clinic and because they're asymptomatic unless somebody brings them in and we identify the symptoms. So I've focused a lot on kind of the symptomatic piece as I'm talking today. There's a question about long-term, it says all long-term progressors. I think it may be referring to non-progressors. So people that have lived for a very long time and have not necessarily become immunocompromised or have had high viral loads. I don't know the terminology that's being used now because most of these individuals are on therapy in my experience, and some of them are in my studies. So I do see people with a cognitive syndrome, despite having gone for decades without needing treatment, maintaining high CD4 cell count and viral load. So I would argue that it's not completely exclusionary. Would you offer treatment for attentional deficits as compensatory measures to improve quality of life? I can tell you that I often will work with people around attention. We have a study trying to assess mindfulness-based stress reduction. The data on using medications for attention, I think there has been maybe one small study, but there really aren't enough data to support that. So I think that's a bit of a challenging question to answer. I think some people have used medications. I in my practice, don't. For attentional deficit. Do baseline HIV viral load and CD4 cell counts predict development of cognitive impairment later in life? This is a quite difficult question to answer. I don't know anyone who has looked at baseline viral load as in how high the viral load is at seroconversion. That we are beginning to look at in an acute HIV cohort in Bangkok, Thailand, that we've been following now for over 10 years, but those data are generally not available. I also don't know of anyone who's looked at the set point. Maybe there's somebody listening to this call that can correct me by email, but the set point at which people are in terms of viral load. There are quite a few papers suggesting that the lower your CD4 cell count was historically, the more at risk you are for cognitive impairment. So that may well be a disease severity marker. So the nadir, we call it, is linked to having cognitive impairment later in life. Another question that I often get that's not part of this, but I'll go ahead and answer it anyways, is that that of duration of HIV. So how long have you lived with HIV is a question we ask in our research studies all the time. And we try to clarify it as much as we can to when they were diagnosed and also when they think they were infected. And when we look at that in all of our studies, it doesn't seem to matter. But we have a very select group of people that I'm caring for in my studies, or that I'm seeing in my studies, and these are often survivors. These are people that have been living with HIV, some for 4 decades, documented 4 decades, because there was a study here in San Francisco that had stored blood and went back into the late 1970s and tested once the test was available in the 80s and found that many people had HIV in 1979, 1978. So when you look at somebody, when you're looking at a group of individuals who have lived with HIV for so long, what you can't account for are the people who didn't live to be in your study, and that's a survivor effect. So trying to look at duration of HIV, particularly for people living over 60, I believe is conflated by the survivor effect. And that's probably why when we try to regress and understand duration of HIV, we don't get very far at understanding that. Perhaps it's different for younger people. Perhaps it's different for people that were infected after 1996. I don't have the answer to that, and I'm not sure of any data where that's been looked at. So is it possible that duration has an impact in people in the more recent eras of antiretroviral therapy? I don't know the answer to that, but we certainly aren't finding it in our older people. There's one question here that I'll read in terms of improving quality of life. Would we do better to put resources into cognitive testing or assessment and rehab with good occupational therapy? There really are a couple ways of looking at that. I think there are some research questions that need to be answered, particularly around people living into old age and whether there are ways that we can identify and target therapy. So are there mechanistic links that we can find? But the question also has some commonality with the sense of futility that I was talking about. Many of the things that I was offering in terms of things to do are what I often say, the things your mother told you to do. And I imagine there are many of the things that you're already telling your patients to do. And I think supporting that is important as well from a clinical standpoint. So I support trying to get people to have cognitive opportunities for compensatory strategies that could fall into the realm of occupational therapy. I would support that as well. So I'm not, this next question, how soon after diagnosis with HIV is it recommended that you begin treatment? I think guidelines are broadly now recommending test and treat in many, if not most places around the world. From the setting of HIV, there's no reason to believe that that's not going to be helpful. We are testing that question now in this cohort that I follow in Bangkok, Thailand, trying to identify whether we find abnormalities in people who were started therapy during acute HIV. So there's a lot that we don't know, but the guidelines are pretty clear that when you identify somebody with HIV, treatment is indicated. That next question, I'm sorry, I can't read. There's a question here about longitudinal cognitive testing. I do think that if you were trying to identify people with Alzheimer's disease from people with HIV, longitudinal cognitive testing will give you the answer. I think it's going to take 2 to 3 years. So I think that question is right on the mark, but also not going to be the answer for us to help people now who are coming to see us in the clinic. And let me see if I can take one more question here. One question is asking if there are any genetic markers that differentiate Alzheimer's disease from hand. And I would say that in the absence of some autosomal dominant disorders that cause Alzheimer's disease, I'm not aware of any genetic testing that will distinguish the two. I've published a couple papers looking